We would first start with a talk by Professor Namrata Sharma on conventional capsulorhexis techniques in intumescent white cataract. May I invite the co-instructors on the dais, Dr. Rohit Om Prakash and Dr. Abhay Vasavada, sir.
So thank you, Manpreet, for making me a part of this instruction course, and I would be talking to you about capsulorhexis and white cataracts through the various videos. So this is just to show this is a case of white cataract, and because the intralenticular pressure in these cases is generally high, so your rhexis might get extended, and whenever this occurs, then one has to put a viscoelastic at the side from where it has extended, which also helps you to visualize where the extension is. And with the help of the capsulorhexis forceps, then get it on to the correct position. Then this is a case of, again, a whitish cataract where the rhexis extends to the proximal side. And again, one has to be careful that this doesn't go at the back, and subsequently do phacoemulsification in situ without causing much stress on the zonules, and always seeing that the chamber is entirely filled up and the chamber doesn't collapse, and then subsequently the case is completed. Now this is the classic case of white cataract, where as soon as you give a neck, it just goes on either side without giving you any opportunity to correct it. And when this happens, then it is best to come out, put some viscoelastic, and then convert this linear rhexis, which happens in these white cataracts because of intralenticular pressure, into a circular one. So even if you don't have a completely circular rhexis, it doesn't matter. But then again, one has to be careful to cause minimal stress on the zonules, so that your the zipping effect does not happen, and the anterior capsular tear does not convert into a posterior capsular tear. Then this is again a case of white cataract where needling was done and you couldn't make out where actually the rhexis was despite staining it with a trypan blue dye. So in these cases, again, you have to regularize the rhexis by excising it with the help of the Vanna scissors and then making it circular, and then one can complete the case as routinely. Then this is a case which has fibrosis, but because it's a white cataract and you can't make out the ridges and the crests of the fibrotic capsule that are present there. And after you stain it, you can actually delineate the morphology. Again, this is way back we published with Professor Dada to say that if there is a fibrosis which is present, one should encompass the fibrosis and complete the rhexis. Then this is a case, again, a white cataract which has fibrotic capsule, and as soon as you put trypan blue, you can see the morphology of the fibrotic capsule. And when you do that, then it is not possible to actually complete it with the help of the scissors or with the help of the forceps. So you would have to excise some parts of it so that you come to the area which is non-fibrotic, from where you can pull the rhexis easily. So it is cut and pull, cut and pull. So with the help of the capsulorhexis forceps, it is pulled, but as soon as you come to the area of fibrosis, then you would need to put, you would need to use a Vannas to cut that area so that there is no irregularity and you get a complete rhexis. Then this is a case again of a white cataract with fibrosis that is present, and like earlier we said, you have to encompass the fibrosis, but here you can leave the fibrosis because it is present right at the periphery, because this is also adhered to the area of the iris, and you don't know the status of the rhexis in the iris there. So after you complete the phacoemulsification, then one can put the IOL and can then address the fibrotic part. Then this is a case in which the corneal opacity is also present with a white cataract, and when you have this kind of a cataract, then you do the rhexis. But as you come to the area of opacification, you have to go in one go. So in one go, just complete the rhexis in one go as you are underneath it. Don't leave it there, because if you leave it, then it will become very difficult to visualize it and to pick it up again. So underneath this, you have to go in one go. Now this is a case of tuck-in lamellar keratoplasty, again a white cataract, and here the cataract is relatively soft. This is stained, and then subsequently the rexus is being fashioned here. And as you come here, notice that it is not circular, but there is a small tongue to it which is left. So again, this can be, with the help of the vanners, this can be cut and then can be pulled with the help of the scissors. Not that it makes any difference visually, but otherwise also it is good to have a central rexus, and then subsequently the IOL can be implanted. Then again, I think intraop OCT microscope is a useful tool for capsulorhexis in white cataract. For instance, here you have these black areas, which means that there is no, the intralenticular pressure is not that high. So even if you give a neck and you do a rexus, you will be able to do it because the fluid is not going to come out. And this morphology can be ascertained either by doing a pre-op OCT or even by doing an intraop OCT. So the rexus is initiated and subsequently the rexus is completed. But this may not be the situation at all the times. Here there are no black areas present, so it is completely filled with fluid. So as soon as you give a neck, there is fluid which is going to come out, which can be seen as a blob. So important thing is that when such cases are there, then you can expect that the intralenticular pressure would be high. So there are several tips and tricks for white cataract capsulorhexis. One thing that I have not shown you is that you can spiral it, which can be done, and most people like to do a small rhexis first because of the raised intraocular pressure and then enlarge it. And I think every case has to be dealt differently. Thank you very much for your kind attention.
Thank you, ma'am, for the wonderful videos and tips. I just wanted to ask you, what's your opinion about people using a phaco probe to make the initial punch, like a punchorhexis? Would you advocate for it?
So I haven't done punchorhexis and I'm not comfortable with it. I'd rather make a small rhexis and then convert it into a larger one, rather than using a phaco probe to make a punch onto the anterior capsule.
And do you think that intraop OCT has added to how you manage the conventional capsulorhexis, or it's just an adjunct that helps you see but not added definitely?
No, I think, see, for most cases you can do these cases even without intraop OCT microscope, but I think in white cataracts it has a special role to play because it helps you to understand the dynamics of the lens better, and also, like I said, whether the fluid is going to come out or not, intralenticular pressure is raised or not, that you can discern better. And Dr. Tityal and yourself have, I think, published some great articles on it as well.
Any choice of viscoelastic OVD?
So OVD, of course, we are going to use dispersive OVD, that is mandatory, and cohesive OVD. Basically what is done is you try to flatten the anterior part or the central part of it so that the rhexis doesn't go to the periphery. So either you can use if you use something like a Helon GV with no financial interest in it, I think that is the best because that will push everything down. But then doing a capsulorhexis would become a little more tricky because you have a lot more resistance to spiral that anterior capsule.
Thank you, ma'am.